What's up, rookies? Welcome to another snippet on what pharmacists do. Here we showcase what pharmacists do and explore inspiring pharmacy career paths. Today, I'm really delighted and honored to have with us Dr. Liseli Mulala, who is going to talk about what pharmacists do in transitions of care, in research, and perhaps a little bit of academia because she has done it all. Thank you so much, Dr. Mulala. Thank you for being here with us. How are you doing today?
I'm great, Dr. Wabo. Thank you so much for having me. I am honored to be here.
Oh my gosh, the honor is mine. I really appreciate you taking the time out of your busy schedule to come and share your amazing journey with me and aspiring pharmacists and pharmacy students and new practitioners out there. So I would like to start by us getting to know you a little bit better. Please tell us about your journey to becoming a pharmacist, from why you chose pharmacy to where you are working today.
So I had a bit of an unconventional journey when it comes to pharmacy. As I started out at Northeastern University in Boston, Massachusetts, as a biology pre-med major. My goal was always to go to medical school. And I started biology, very bright-eyed and bushy-tailed, and about, I want to say, most of the way through my freshman year, I was really bored. I was sitting in botany class, bored out of my mind. And I realized I have no interest in animals or any other thing. I only care about humans. I mean, I love, God made the planet, all living creatures
I
are
get you.
beautiful
I hear
things,
you. Yes.
but I don't want to study them. I only care about what's going on in the human body. So I also did a summer job at a biology laboratory. And also, I was not just bored, but I was also emotionally, I didn't feel comfortable with the animal experimentation that was happening in the lab. And I was like, I can't do this. If I don't get into medical school, I could not do this for the rest of my life.
Yes.
So I talked to some of my friends who were in pharmacy, and it sounded really interesting. And the focus was where I wanted it to be. We're looking at medications, but we're looking at how they act in the human body and what can we do to help people to understand their medications. Like, okay, this is good. I like chemistry. I like human physiology. I like people. This sounds like the right place for me.
Perfect. Yeah. Makes sense. Makes sense.
Then I switched to pharmacy my major sophomore year. I graduated from Northeastern. I went to work for Brooks Pharmacy, which is a retail pharmacy on the East Coast. And then I ended up about a few years in, I started working at a natural health store because I have some interest in homeopathy and herbology. How, we get a lot of medications from natural plants. So I was always very interested.
Connected.
I was bored in botany, but herbology was cool. So then the natural health store owner actually opened a store in Palo Alto in 1999. So I moved out to California from Boston to work at a natural health store. So I didn't actually have my pharmacy license when I first came here. I had a Massachusetts license. And then unfortunately, the store went out of business in 2001. And I ended up taking California boards and getting my pharmacy license here. I worked for Rite Aid in 2001. Then I switched to Walgreens. And I worked for Walgreens for about 15 years.
Wow.
In 2008, I took the APHA Pharmaceutical Care for Patients with Diabetes certificate.
The CD, the certified diabetes.
Not certified, that's different. So that's certified in diabetes management, which is an APHA certification. And then in 2016, I did the certification for diabetes care and education specialist, which is what used to be called the CDE, but now it's called a CDCES because we like to make things complicated and make the acronyms really long. But it also is because we're doing more than just education. So being a certified diabetes care and education specialist is really encompassing everything that we're doing. So, and then I did my master's in public health at San Francisco State in 2010. But this is because when I first went to pharmacy school, there was no PharmD. So it was a bachelor's degree. So I went straight out of high school and got my bachelor's in pharmacy. And then when I wanted to switch fields, it was very difficult for someone with just a bachelor's.
Okay, got
So
you.
that's why I did the master's in public health and did the PhD in public health.
Okay.
It's a very circuitous route, but
yes,
led me to working at San Francisco General Hospital. And my PhD dissertation focus was how can diabetes, self-care, and social support in African Americans with diabetes in San Francisco, because there is a big disparity. So I wanted to see what the successful folks were doing. So what type of support were the patients who were doing well with their diabetes outcomes getting? And what type of support were the other folks not getting? And what I found was educational support and non-judgmental, affectionate support, but also that motivational interviewing. So asking people what they need instead of telling them what to do. Asking people what they need works. Telling them what to do doesn't work. And yelling at them doesn't work.
I know.
But also having the information. So if people with diabetes understand what is going on with their disease and what helps, then they can say, oh, this I can do. Oh, that I can do. And then I'm having trouble doing this part. Can you help me? So it's like the two pieces were needed was the informational support, but also that non-judgmental, affirmative, motivational interviewing support. So my research kind of led me directly to that transitions of care, because what they were looking for was a pharmacist to do bedside teaching and to help to optimize outcomes in patients, not just with diabetes. We're also looking at heart failure, asthma, COPD. But the diabetes, my research kind of put me in a good position. And at my Walgreens that I used to work at, we were also doing meds to beds. Even though it was a retail pharmacy, we were in the hospital setting at St. Luke's Hospital. So it was a great sort of transition, and having the PhD in public health helped me to get into the Department of Public Health. So again, a very roundabout, not a direct
journey.
route.
So you get your bachelor's degree in pharmacy, and then you move over to Southern California and work with a homeopathic pharmacy that ends up closing. And then you have to do something now. So you go work at Rite Aid, and then you work at Walgreens, but you're still thinking, if I want to grow and be better, I have to do more than this. And you're getting your master's in public health, your certifications. You also have an MTM certification. Was that while at Walgreens or while working in retail or after your diabetes certification? Like, because I was pretty intrigued about that. I didn't realize that certification existed.
Yes. So I actually did that as I was working at San Francisco General. Because I am hoping
medication management is a big part of charge.
I'm hoping to become a clinical pharmacist, because I'm a staff pharmacist. The Transitions of Care position is not a clinical pharmacy position. And at the General, with Department of Public Health in general, you can become a clinical pharmacist if you have residency or if you're board certified. So I did the board certification in medication therapy management to qualify me to apply to the next opening that happens, because I'm always thinking,
you're thinking,
what do I want to do next? Where do I want to go? I always want to grow and learn.
So that is a board certification. So is it like a BC, like a board certification?
Like a BCPS, but it's MTM. So it looks at you do have to know disease states, and you do have to do disease state teaching, because now MTM, it's not just the medications, it's the medications and the disease state.
And the disease state, absolutely.
And what I'm doing in the transitions of care and also MedRec is the MTM piece makes a lot of sense. There's parts of it that I don't necessarily need to know. That's more for retail setting, because you have to know about the legal ramifications and the laws that surround medication therapy management, and what certifications you need to do it, and what insurance covers and like billing. So there's a lot of things I don't necessarily need in my position, but it's also good to know.
And
when
it's
I'm
good to
calling
have.
retail pharmacy,
Yeah.
when I'm
Yeah.
talking to MTM pharmacists on the retail
Yeah.
side, what are they
Yeah.
doing? I know now. So
What? So we were at where you got your PhD and you did your
yes.
research and you found these disparities, and how did you get from there to where you're working now?
Yeah. So as I was working at Walgreens and I applied for jobs with San Francisco General Hospital, because we're the county hospital for the county of San Francisco, we
Yes.
are actually part of San Francisco Department of Public Health.
Okay.
So that was I didn't care where, but I just
Mhm.
wanted to work somewhere in DPH.
Mm-hmm.
And the job at San Francisco General opened up, and it happened to fit my qualifications very well. It's transitions of care, and also creating the transitions of care program, because before then they didn't really have a full-on TOC program.
Okay.
It was basically they were just delivering medication to the bedside, and the pharmacist would talk to the patient about the medications, and that was it.
Yeah.
So the full TOC means you're also doing that disease state teaching, you're doing the analysis, you're doing the follow-up phone calls, that you're creating this setup that helps the patient to transition effectively, but then you're also checking in.
Yeah.
So adding those pieces, and also when I first started, diabetes wasn't a part of it. And I was looking at the proposal, and I said, where are the diabetes patients? And the only thing that was on there was teaching about insulin. But you were teaching about insulin, but you weren't talking about anything else
Yeah. What
about
about
disease
diet?
state.
Yeah.
What about diet? What about exercise? What about getting your feet checked? What about mental health? What about stress? How does stress affect your blood sugars? Do they know what an A1C is? Do they understand why they have to get their kidneys checked and their eyes checked and
Do
their
they
teeth checked?
understand?
So
Yes.
all of these pieces were
Or
missing.
not included. Yeah.
Yeah.
Okay.
So I asked my boss, I said, why aren't we doing this? And she said, I don't know. Why don't you do it? And I said, that sounds like a great idea.
Okay.
So
Okay.
I was given the time
Mm-hmm.
and the resources to
Create that.
research what was missing and what other people felt they needed, because I'm not the only person who does discharge counseling. The clinical pharmacists on acute care also do the transitions of care for the patients on their team, but there are multiple teams at the hospital that don't have a clinical pharmacist. So I'm primarily responsible not for their acute care, not for their inpatient stay, but at the end, when they're doing that transition, the discharge, I will counsel those patients, and I will also help the clinical pharmacists to counsel some of their patients as well. So I had to make sure that I could spread my knowledge to all of the pharmacists that would be involved in this process, and any pharmacist that wanted to learn. So if for some reason on the weekends and holidays and evenings, there's no person doing that bedside teaching, they will send the patient down to the discharge pharmacy. So those pharmacists also need to know, what do we do? And so there's a set protocol, there's handouts, there's a roadmap of what you should cover, and it's all available on our intranet, but most people didn't know how to find it. And most people didn't feel comfortable doing it, because like we all learn some form of diabetes in our pharmacy schooling, but if you don't use it, you lose it.
Absolutely. Yeah.
So I created like a 1-hour review course on what you need to do to teach patients with diabetes.
Wow.
I also
For your
created
team.
a program for the team, and created a program slightly different for the nursing staff. I created these little teaching kits for all the units. And then I did a review of how many patients were actually getting the teaching. So that was, again, the research kind of came in.
Yes.
As like, what are we going to do?
Win the
Why are we going to do it?
Yeah. I want to talk about your research award that you won. I'm not sure if it's an award or
okay.
a certification, the Enrich 2023 award from SF San Francisco General. And up to now, you still haven't said that you work at San Francisco General Hospital. And as part of all the work you're doing, and you use the data from all the work you were doing and came up with some interesting data, and you won this award. Can you tell us about it?
So it's the Enrich It's a scholarship that is awarded by the Academy of Communication and Healthcare. And the Academy of Communication in Healthcare is a international organization that started in the 80s. It's multidisciplinary, and they focus on communication in healthcare. So they actually created a project around equity at our hospital called Relationship-Centered Communication for Equity. And I was lucky enough to be in the pilot group to take this course. And after we took the pilot course, they asked which of us wanted to be facilitators to teach the course to other people at the hospital. And we're focusing on effective, equitable communication, which for me, it's like, this is completely relevant to my job.
That's
That's what I do all day long. And with this course, like this group ACH has, they've been studying this for, over 30 years. They know what works and what doesn't work, and also how to pivot. When what you're doing is not working, what else can you do? So I was learning this, and then they told me about a conference that they have every year called the Enrich Conference.
Where you what does that stand for? Do you remember?
I don't know. I know Enrich is just for the conference, but it's basically focusing on this relationship-centered communication, or RCC. And there's different portions of it. One is just introduction to RCC, but our portion is just RCC for equity. How do we communicate most effectively to reduce disparities and remove barriers and help people to be on the same page, no matter what your position is? So that hierarchy, and no matter whether you're a patient or a provider, whether you're a nurse or the attending or the pharmacist or the intern, or the CNA or whoever you are on the team, that you can have as important a voice in the conversation. And it's not just like this top-down approach. It's like, I'm your provider and I'm telling you what to do. Like, what questions do you have for me? I mean, that's a simple, we always taught this in pharmacy school, but why? So this was a great opportunity for me to learn the why. But also the conference that they have in Austin it's like $600, and then the hotel.
Those conferences are expensive in general.
So the scholarship just covers all my costs. I get to fly out there, and I stay for all 4 days, and I'm going to learn how to improve my communication for equity, but then I'm also going to bring the tools back to the hospital. And I'm on the equity council at the hospital, and I'm also part of equity champions. So as an equity champion, I'm going to bring this information back from the conference and just share it with not just folks in the pharmacy department, but across the hospital. So I was, very honored. I filled out an application just like a lot of people did, but I guess my appeal worked.
Congratulations.
Thank you.
And I think many, it's something for pharmacists to know and look into and see, because this is a training that your pharmacists at SF General are going to be lucky to have that from you, because I wish it's something that all of us can get, because we're all in the business of communicating with patients from diverse backgrounds and trying to improve patient outcomes for them. So
I don't know how available it is freely, but if you look up Academy of Communication in Healthcare, you can see if they have courses available, and sometimes they have scholarships, sometimes they have, they're at conferences, and you're looking for relationship-centered communication. But I recommend the one for equity. That's the one that I like.
Relationship-centered communication. Yes. So so you really were prepared, and then with all your certifications and your degrees, and then perfect timing, this job opens up that like matches all your accomplishments, and you have this opportunity to start this brand new, or maybe not brand new, but like revamp this Transitions of Care program and include more details about diabetes. So can you elaborate on what, just for people that don't understand, what you've talked a lot about it throughout our conversation, but what is a Transitions of Care pharmacist, and how do you do transitions of care at SF General?
Okay. So in general, a transitions of care pharmacist is preparing the patient from the transition from one setting to another. So in my case, it's going from the inpatient setting back
Yes.
home or back to the outpatient setting or back to wherever they came from.
Yes.
It can also be going from a long-term care facility to home or the other direction, going from home to long-term care facility. So you're transitioning the patient from one setting to another.
Yeah.
And usually that transition involves med rec, medication teaching, disease state teaching, or disease state assessment.
Yes.
So if someone's newly diagnosed, you're telling them all about the disease. If they've had it before, you're assessing their knowledge, because usually if they have a exacerbation of a disease state,
they're not doing something right.
something is missing, something didn't go well. And sometimes it's not their fault, not that it's anyone's fault. We don't want to fault people.
Yes,
But
absolutely.
sometimes it's something that's beyond their control. Like they got an infection and that caused their diabetes to blood sugars to go up. So they end up coming in DKA because of the infection.
Yes.
Or it's because they ran out of medications because their doctor did not send the refills.
Or
So it's not non-adherence, it's a systems failure.
Yeah.
So having the conversation is to figure out what happened and then also try to prevent it from happening again. Or giving them the knowledge.
Maybe they need some kind of financial assistance to
Yes.
the medication. Yes.
Exactly. This medication is too expensive. It's not covered by insurance.
Yeah.
Nobody, told me that there was an opportunity for a generic or an alternative medication. So I just stopped taking it because I couldn't afford it.
Yeah.
So making sure we catch those gaps and those errors, and then making sure the patient understands there's also a component of follow-up. So we do follow-up phone calls for heart failure, diabetes, and asthma, and we might start doing anti-coag follow-ups. But we have a set questionnaire, and we call the patient up a week or so later and check if, are you checking your blood sugar? Are you exercising? What are you eating? And then making suggestions, if necessary, to change things. Are you weighing yourself? Are you checking your blood pressure? Do you have your maintenance inhaler? Do you have your rescue inhaler? Do you know which one is which? And how often are you using your rescue? Have you had, exacerbation in the past week? So if we can catch someone before their symptoms get too bad, maybe they can be stabilized at home, which is always preferred. Or we find out that what we taught them in the hospital is working. I'm exercising every day. I'm eating more vegetables. My blood sugar this morning was 95. Awesome. Thank you. I'm so happy for you. That's wonderful. Is there anything else I can do for you? What more information do you need? What type of support do you need? So making sure that we're doing that check-in with the patient, but it's on as I'm learning more about communication, I'm doing things like, what else?
Yeah.
Instead of, okay, that's great. Let's move on to the next thing. Is there anything else?
All I know about communication.
I never even thought about it.
I really wish all pharmacists can have access to it, because all I know about communicating with my patients is ask open-ended questions.
Yes.
But I'm sure.
And that's just the first part.
Yeah, that's just the beginning.
There's more to it.
Yeah, there's more to it. And you did say, you did use the perfect expression, catching the gaps.
Yeah.
As a transitions of care pharmacist, you're there to catch the gaps as patients are transitioning from one setting of healthcare to another setting of healthcare, or no, to another setting, because it could be their home.
Yes, it could be their home.
And you did mention doing some research, because the question I wanted to ask you was, what impact does transitions of care have on patients' outcome? And you did happen to do some research that highlighted some of those impacts. Can you talk about that a little bit?
Yes. So some of the research I've done is mostly assessing the impact of our discharge counseling on patient outcomes. And one of the standard measures that we use is readmission rates. So looking at whether or not our discharge counseling for diabetes, for health care, for asthma, heart failure, for asthma, is reducing readmission rates.
Right.
And that's usually the goal. And what we did some research on our diabetes education, we found that it was reducing readmission rates in all populations, which was unusual, because usually you see higher readmission rates for African American, for Latine patients,
Yeah.
and lower in white patients. And we saw lower rates for Black African American, for Latine, for white, but we did not see lower rates for our Asian American, Native Hawaiian, Pacific Islander patients. We actually saw higher rates after our diabetes teaching. We're like, oh, what is happening here?
Yeah, what's
So
happening?
if we hadn't done the research, we wouldn't know that there was this disparity that was
Yeah.
happening in this specific patient population. When we look a little deeper, we see that it's not happening with our Chinese, Cantonese, or Mandarin speaking patients. It's happening with our Vietnamese, Thai, Korean, Japanese, because we did not have diabetes materials in those languages. We only had them in Chinese characters. We did not have them in those other, and there were materials that were available, but they were outdated. So I was able to get a grant to get translation services and update the materials, and those specific languages were focused on. And we also tried to make more culturally concordant dietary educational materials.
Yeah, that's
reflecting
important.
foods
Yeah,
that people actually eat, as opposed to what we call the typical American diet, which if you look at this country, it's not very typical. It's only like certain groups will eat those foods that we call the typical American
absolutely.
diet.
Yeah, because when you talk about my plate method, it means different things for different for people from different cultures. It's not
right.
not
And even
always.
within this culture, there's people from all over the planet. So if you look at somebody, it's like, just because, someone, like, I was born in Zambia, but I immigrated here when I was 8 years old. My daughter was born here in San Francisco. But if you look at her plate, it's going to be, we lived in Zambia, we lived in Peru, we lived in Jordan. So any day of the week, you've got Zambian food, you've got Middle Eastern food, you've got,
Oh my
you've
gosh.
got all the food.
Yeah.
So when I think of a healthy plate, I ask people, what do they eat?
Thank you, Dr. Mulala, for sharing your work with us. Now I want to ask you my favorite question of all when I speak to pharmacists. What do you like most about being a pharmacist?
Well, I like talking to people. That's my favorite part. So
communication, RCC.
Having, now that I also enjoy the chemistry and the pharmacology and understanding how medication works and what they do and how they do it. But the most important part to me is the communication of that information. How do I communicate this information to someone and have them understand it in a way that makes sense to them? And the most rewarding part for me is when I see that light bulb go off. And
in the patient's eyes.
They get it.
They
get it.
Yeah.
And then when I do that follow-up phone call and they really have it and they're so excited to tell me about what's going well. And it's usually in the beginning, it's like, oh, everything's terrible. This is not working. I can't do this. And then we have the conversation and I try to answer all their questions. And then I call them a week later. It's like, everything's awesome. I am doing so well right now. Let me tell you what my blood sugar is. And they're excited to talk about it instead of, oh no, terrible. So that's my favorite part, is the light bulb and the happy joy.
And I've encountered that too. I've encountered where, because we do some diabetes educations too, and I've encountered patients say, when you hear patients say, that you're going over their blood sugars and it's all at goal. And then there's this one day where it was above goal and they were like, but it was my birthday and I had some cake. But then I went out for a walk after that, or I walked 15 minutes longer after that too. And you're like, oh my gosh, they know what happened. They understand it. And they actually know that taking that extra, adding 15 or 20-minute walk because they had the cake could help with the A1C or the blood sugars in general. It really makes me feel like so proud, like I've done a good job of educating the patient about the disease state, and they get it, and they know what to do. And I feel like if I wasn't there for them today, they would kind of be okay. I totally hear what you're saying.
That's my goal, is for them not to need me.
That's what I want. Absolutely.
I want them to graduate and fly free and do well.
Yeah, yeah.
Just like with my students. So I also like the academic piece and the
Yeah,
same
we
thing.
didn't talk
Like
about that. I saw you. You know, when I
yeah.
saw you, I meant to say this in the beginning. I met Dr. Mulala on LinkedIn. I was just enjoying your posts, enjoying all the inspiring quotes and educational materials that you were posting. And then I asked you if you can come on and talk about transitions of care, and you said yes. And then before we set up a meeting for today, and then before the meeting last week, I met you at the Touro University, California College of Pharmacy commencement ceremony. And I didn't even know you were going to be there to begin with. I was like, oh, this is fake. This was meant to be. And you
Exactly.
hooted so many. I mean, you hooted at least one or two students that I saw you heard. And then you took pictures with so many students. And I really meant to ask you about that side of your journey as a pharmacist. Can you, because I think it kind of ties in with what advice do you have for people aspiring to becoming a pharmacist, for pharmacy students, and for new pharmacy practitioners about how to be happy in their pharmacy career and how to set themselves up to have the best impact they can have on patients, patients' care?
Well, I think the most important thing is to find that joy, find that happy place. And there are, unfortunately, some people in our profession who are very jaded and they are not happy.
Yeah.
You can tell. And it's not a great place to be. So I advise people, don't listen to the negativity that you can sometimes find in the profession. That's not to say it's not true.
It is true.
And there's some places that are, and there's some times where it's just really hard. But I also say find the joy. So what is it that you like about what you're doing? And what is it you don't like about what you're doing? And in my case, the good definitely outweighs the bad. I mean, there's things I don't like about my job. There are things everybody doesn't like about their job. But what I love about my job greatly outweighs the negativities that I have. So the benefit should outweigh the negative. If the negative is outweighing the positive, then you want to try to reposition yourself to be able to find another job. And I always say, make sure you have another job before you quit the job that you have. This is very important.
And sometimes though, I've heard people just walking out.
Yeah. But I also feel like if you get to that point, like it didn't start there. Things have been slowly getting worse and worse and worse. So when things slowly start to get worse and worse and worse, that's when you start looking. So I started looking for my next job before I had it up to here, the job that I had. So I left in a good place, and I didn't burn any bridges when I walked out. Not that I would go back.
Very important.
Still, it's pharmacy is a small world, and people keep saying it because it's true.
Yeah.
You want to make sure that you don't burn bridges, but also, what do you like? What do you not like? And also when you have preceptors. So as a preceptor, I precept a lot of students, and I would tell the same thing. You can take what you like about what I'm doing, and if you don't like something I'm doing, do differently. And let me know. What is it that I'm doing that is not working for you? But also you take the good and you move on with that.
And you make it your own in some way,
and you make it your own. And I always try to pass on my knowledge, pass on my joy. Like, this is what I love about pharmacy, and maybe you love it too, maybe you don't love it, but at least you can see somebody who has joy in their work, and that I want them to move on and find something with joy in their work, and also encourage the people that are struggling and just say, you know what, maybe you haven't found your place. You can find, everybody has strengths. And you made it this far, you could do this. But what do you want to do with it when you're done? And you have to figure that out along the way. So that's why I say, look at your preceptors. This is somebody whose job, I want to have a job like that when I get out. I don't want to have a job like that when I get out. I'm going to do it like this. I'm not going to do it like that. Just keeping, take the good, take the bad. And it's like also, and it may be bad. The different. Somebody's good might not be your good. Everybody's different. So, I just try to make sure I pass that on and make sure you can learn something from everybody, everywhere you go. you will learn something.
I believe
Whether it's what you want to do or what you don't want to do, you will learn something. And also be positive. Try to be positive and pass on the positivity. You know, the world is hard enough as it is. We don't need to.
And I can tell you're positive because students are already very nervous when they're rotation. And it's amazing to have a preceptor that understands that you're there to learn and are not jaded, like you said, and kind of really I could tell the students were happy to have you as a preceptor, and that means that they were comfortable at your site. They felt supported, not belittled, or because precepting really is, there are preceptors that don't understand, that are impatient with students and that understand that they need to start from a certain level and grow. But finding your joy, like you said, is a journey. Personally, I think I am still on that journey, and I think students should understand that, or aspiring students, that finding your joy is a journey, and then you have to start somewhere. Like you said, that's why you don't listen to the negativity. You have to, if you're in a setting where you don't want to be, you still have the opportunity to figure out what you like and what you don't like, who you want to be like you said, and who you don't want to be like, and just continue to, like you have done, continue to just educate yourself, because you realize, okay, I like communicating with patients, and then, you know, diabetes shows up, and then you decide to, you know, better yourself and get more knowledge in diabetes, and then communication comes up, and then you have all these communication conferences and certifications. Just, I feel like it's a journey. I think what I'm trying to say, it's a journey, and you have to dabble into different things, work with different people in order to really figure out what you want. Don't listen to the negativity, and it doesn't just have to do with what's happening with retail or certain fields of pharmacy. It's also what's happening with even pharmacy school in general. Now they're saying, don't go to pharmacy school because there are no jobs, or it's too expensive, do nursing instead because it's fewer years and it's less student loans. And I say, don't listen to that. Just listen to what you want to do. You wanted to be a medical doctor, and then you realize that botany wasn't for you. You realize that, you know, you have to start, do and figure out what you love and do what you love. And I think once you start doing something, once you know what you love, then you'll be guided, like into what the next step is. So I really I wrote down, don't listen to the negativity, find the joy, and be positive.
Yes. And also I would say that don't always listen to the route that people do. So you heard my journey was not a straight line.
Yes.
And there is definitely this push that everybody has to do residency. Not everybody has to do residency, and not everybody can do residency, and not everybody should do residency. If that's where you want to go, then you should try to make it happen. But if it doesn't happen, it's not the end of your journey. So if you practice for 4 years, you can get board certified. And some places, and actually smaller hospitals in rural areas, they don't care if you have a residency or not. It's work experience. So trying to get that experience is maybe the way to go. And then once you have the work experience, then you can apply for those other jobs because you already have that work experience. Yes, I was a clinical pharmacist at such and such hospital for 5 years. And that will be as good, if not better, than a residency, because you're getting that on the job training. Do you want to do research? Then you don't need residency, you need a fellowship. You know, it's just like, do you want to get a PhD? Then you want to do research. That's what you want to go to. That's your route. So for me, it was like residency was not an opportunity when I graduated from pharmacy school. So I figured out another way.
You know? Residency wasn't an opportunity for you. PharmD wasn't an opportunity.
It was not an opportunity for me.
But look at you now.
I got a PhD, and then I got my work experience. So even though I'm not a clinical pharmacist, I'm doing, in some cases, similar work
that
I can translate as work experience. But then I got board certified because I know that that's a requirement. So there's other ways to do things. It's not always.
Absolutely.
There's more than one way.
And that's why I really love doing this video, because it kind of showcases various pharmacy paths, various pharmacy journeys, so people don't get discouraged or feel defeated when they're not where they thought they should be at particular points in their lives or in their careers. And I really thank you for coming on and sharing your amazing, non-traditional path and journey to pharmacy, and the amazing work you're doing right now.
Thank you so much.
Thank you so much. Thank you everyone for listening. If you enjoyed, were you going to say something else? I don't want to.
No, I just wanted to say thank you so much, Dr. Webo. It was a pleasure talking to you, and you are an inspiration. You are out there sharing this knowledge and sharing your joy and your path with everybody, and I really appreciate it.
Thank you, thank you, thank you. I really appreciate what you said, because it makes me feel like I should keep doing it. So until the next episode, everyone, please stay blessed. God bless you. I love you. Bye-bye.
Bye.